Good evening, dear colleagues. I wish you all the best and to you and your family. And I really thank you for the invitation and efforts for organizing committee to ensure our days 2021. My topic for today is anesthesia, consideration of neurovascular procedures. As you know, nowadays cerebral disease are leading in causing mortality and morbidity. You must know that there are several procedures. There are several procedures that can do in neurovascular disease, in cerebrovascular diseases, and these procedures are a very interesting one. And with very impactful on morbidity and mortality. As you know, stroke is the third leading cause of death in developing countries. 60% of stroke patients are discharged with disabilities. This is a big economic cost and to increase mortality and morbidity, as I said previously. And of course, in case of large vessel occlusion, 10 to 40% of the patient will have significantly good outcome. There are some procedures that are done in cerebrovascular disease, like thrombectomy, angiography of diagnostic angiography, I mean cold embolization, stent and stent assisted. As you see in the slide, they can all the classification of interventional neurological procedures published in British Journal of Anesthesia. Thrombectomy is the first one. Thrombolysis is, can be done within 4 hours from the arrival and diagnosing the patient by ischemic insult. Endovascular thrombectomy of anterior circulation by large vessel class is gold standard, and clinical outcome is time dependent with thrombectomy that can be done within 6 hours of patient arrival in hospital. In this, in this slide, it's a very interesting one article published in British Journal of Anesthesiology that explains all the steps of protocols. So if the patient is suitable for thrombectomy, then anesthesia team can be ready for sedation, for general anesthesia with all equipment and facilities. After that, the anesthesiologist must discuss with all the people that are taking care to the patient with neurovascular and interventional team about anesthesia approach. For example, a non-cooperative patient or comatose patient or a patient who is hemodynamically unstable with large nausea and vomiting can be done by general anesthesia and not by sedation. There are three main papers published in this situation that are the sedation versus intubation for endovascular stroke treatment, siesta, published in International Journal of Stroke, the anesthesia during stroke, published in Stroke, and general local anesthesia in intraarterial therapy or Goliath trial, published in JAMA Neurology in 2018. Let's take a look regarding this. So, general anesthesia versus conscious sedation for endovascular treatment for acute ischemic stroke. The conclusion is that in endovascular treatment for acute ischemic stroke, no difference was found between general anesthesia and conscious sedation in neurologic outcome 3 months after stroke. The second one is monitorized anesthesia care versus intubation for vertebral basilar stroke endovascular. That was a retrospective control study with the patient from 2005 and 2015, done by Pittsburgh University Medical Stroke Center and Neuroscience Central Memorial Hospital in Atlanta, Georgia. There were enrolled 215 patients with vertebral-basilar stroke, and done 36% with monitorized anesthesia care, and 64% by general anesthesia. The conversion rate from monitorized anesthesia care to general anesthesia was 13%. So the conclusion and relevance in endovascular therapy for acute posterior circulation stroke, MAC is feasible and appears to be as safe, as effective as general anesthesia. And future clinical trials are warranted to confirm these findings. In JAMA Neurology in 2016, there was a published paper, effect of conscious sedation versus general anesthesia, Siesta trial, that compared sedation with versus intubation, done by Heidelberg University Hospital, with 150 per patient with acute ischemic stroke in anterior circulation, and there was no difference in between the people done by general or by general anesthesia or by conscious sedation. Among the patients with acute ischemic stroke in anterior circulation undergoing thrombectomy, conscious sedation versus general sedation, general anesthesia did not result in greater improvement in neurologic status. So the findings do not support an advantage for the use of conscious sedation. Why we can do JETA? Better airway protection for CO2 dioxide carbon monitorization in uncooperative patient with reduced Glasgow coma scale, with nausea and vomiting, especially for posterior circulation occlusions. We can do general anesthesia, immobilize the patient and reduce the interprocedural injury, and perhaps it will be preferred by a neuroradiologist. So it's very important to talk with neuroradiologist team in order to stabilize what kind of anesthetic approach we can do to the patient. Why local or sedation? So local anesthesia or sedation, conscious sedation is especially chosen in a cooperative patient with better neurological interoperative assessment, minimize hemodynamic perturbation after induction, and the procedure can begin quickly. So the anesthesiologist is not losing time in order to become as soon as possible the procedure and thrombectomy. Of course, in the principles of anesthetic care, we must take care about the standard monitorization plus invasive blood pressure measures, long circuits so we can monitorize the CO2, rapid induction celiac method if JETA is chosen, and we can use benzodiazepines or dexmedetomidine or remifentanil for sedation. Hyperglycemia and hyperthermia are detrimental and should be avoided, and we can maintain a blood pressure 140 till 180 millimeter mercury scale. This is a protocol published in British Journal of Anesthesiology, Anesthesia for endovascular thrombectomy, and this is you can see in the slide that the protocol is already done, and we have taken care about all the situation, including general anesthesia, to become with all the equipment and the team, in order that we can proceed from conscious sedation to general anesthesia if needed by the procedure or by the patient. Embolization procedures are very common also, and regarding anesthesia care, we can maintain and induce hypotension in order not to be ruptured again the aneurysm. The aneurysm, we can reduce blood pressure by 30% from baseline, especially JETA, so general anesthesia is preferred with smooth induction, avoiding sympathetic stimulation, and of course with invasive blood pressure monitoring before or prior anesthesia induction. Controlling the blood pressure is very important for the anesthesiologist, and you must know that there are plenty of literature and paper published in current opinion of anesthesiology and current opinion in critical care. So if it's very a severe ischemic lesion, we can maintain the blood pressure between 140 and 160. But if it's a hemorrhagic stroke, probably the blood pressure will be a little bit lower than 140 in order to realize or to control the intracranial bleeding. There are some complications that are regarding with procedures during embolization, like rupture to manipulation of hypertension, bradycardia, and transient asystole, glue migration due to massive hyperflow, arteriovenous malformation causing pulmonary embolism. Adenosine that is used by neurologists can reduce the flow and can cause rhythm disturbance and of course side effects of embodied materials that are just put in the vessels of the patient. Of course, there are some complications regarding the, let's say, the thrombolysis and the plasminogen, so tissue plasminogen activator, or some hemodynamic disturbance that are related with nimodipine nimodipine or nicardipine or papaverine that is used by neuroradiology team. So a good and strong collaboration between two equips, two teams, between anesthesiology team and neurovascular or neurointerventional team is very important in order to guarantee a greater success. So if the patient, if the team of neuroradiology intervention team, let's say, can do or they are needed to do or to inject papaverine intraarterial, so the anesthetist must be aware in order to prevent further hypotension of the patient. So this collaboration is very important. Cardiac stents are very common in our hospital. Of course, there are some issues to be discussed here, like adequate sedation and monitoring. If the patient is under antiaggregant and anticoagulant drugs, we can maintain a mild hypertension, but correct communication with members of the team. And of course, in postoperative monitoring, multidisciplinary team treatment and evaluation by cardiologists, neurologists, and by physiotherapists. But you know that during the opening the stent, during the procedure, the patient can have a significantly bradycardia, so the anesthesiologist must be prepared to treat it. The procedure is done under monitorized anesthesia care, and the patient sedated but awake with general anesthesia for intracranial stenosis. A sheath is placed in femoral artery, which can be facilitated by the neuroradiologist and can facilitate their work. But take care about hypertension, of course, and with bradycardia that can be caused by opening the stents in carotid and stimulation, causing a reflective bradycardia that must be treated aggressively by the anesthesiologist. Which are taking home messages: team spirit and best coordination it's very important. It's half of the work, patient-based evaluation and anesthetic approach, and of course, good knowledge and serious update in order to guarantee the success of the patient and the treatment. And of course, a multidisciplinary team, including neuroradiologist, interventional, neurologist or anesthesiologist and intensivist, physiotherapist, and nursing care as well. I really thank you, and I wish you good luck in your family and in your healthy. And of course, mm, it's a very good coordination and collaboration between Balkan states, facilitated by our colleagues, our Turkish colleagues. So I think that probably uh, this tradition can go further with other Arab days and Balkan days, and let's hope without COVID pandemic area. Thank you very much.